The cover story in the current, now August, issue of Cardiosource World News is Double Trouble. It is the Heart-Kidney Nexus, which is one reason why I've been looking forward to this interview. We're talking about revascularization in patients with multivessel CKD and chronic kidney disease, everolimus eluting stents versus coronary artery bypass graft surgery. It is the September 15th issue of JACC, and I am here with Dr. Sripal Bangalore, who is an MD and Director of Research at the Cardiac Catheterization Laboratory and an Associate Professor of Medicine at the New York University School of Medicine. This is a great topic. I mean, there is so much now that is going on in terms of the heart and the kidney. What was your interest in putting this paper together in the first place?
Yeah, that's a great question. So, as you know, the patients with chronic kidney disease, it's a growing group of patients. We have this exponential increase in obesity, diabetes. So this is a growing group of patients, but if you look at randomized trials, every trial would either exclude those patients or include very small group of patients.
Right.
So we just don't know what to do with them. And what we have been doing is we extrapolate results from trials we did not enroll kidney disease patients, and we say, oh, maybe that worked for them, maybe it should work for patients with kidney disease. And this was kind of the genesis for this study. So we said, let's look at outcomes in a real world and look at bypass surgery versus PCI in patients with kidney disease.
So this is why when you started the paper, you talk about the treatment risk paradox, and that's what you were talking about,
Yeah,
the
absolutely.
fact that we don't want to treat these people in clinical trials because it's really it's a group we don't know.
Interestingly, we don't want to treat them. I mean, it looks like we want to do everything for a patient who comes in with toe pain, but the patients who have the highest risk, we tend to undertreat them, not do anything for them. So I think, there is this data to suggest that patients with chronic kidney disease from a cardiovascular perspective are undertreated, even though cardiovascular disease is the leading cause of death.
So tell us about the paper. Tell us about the study.
Yeah, so what we did was we used the New York State Angioplasty Registry and kind of linked them with the New York State Surgical Registry. And we looked at patients with GFR less than 60, so anybody with chronic kidney disease. We did categorize them based on their kidney function and looked at outcomes for patients who had the latest generation stents. There have been some studies where they've looked at first generation stents, but we have moved far from first generation stents. The outcomes with newer generation stents is much better. So we wanted to look at the latest data. How does CABG compare with the latest generation stents? And so for this particular analysis, we used propensity matching, and we had a lot of patients, 6,000 patients who were propensity score matched. And we saw some interesting results. What we found was in patients who were undergoing CABG, there was upfront risk. So upfront risk of death, MI, and also repeat revascularization and stroke. But for PCI, there was late risk of repeat revascularization. And in patients who were incompletely revascularized, there was increased risk of MIs. So in other words, I think the bottom line is there is no one-size-fits-all approach. You have to weigh the risk benefits, patient preference matters, so heart team discussion matters, and you have to consider the pros and cons of both approaches.
Now, the one thing this study doesn't do is it doesn't get to where medical therapy fits in vis-a-vis revascularization or CABG.
Right. So that's a great question. I'm glad you're asking this because we're doing a large randomized trial.
Nice.
It's an NHLBI-funded trial called the Ischemia CKD trial, where we are enrolling patients with GFR less than 30 or on dialysis and asking exactly the same question. If they have abnormal stress tests, should we medically manage them or should we revascularize them? So this is a large randomized trial currently ongoing. We have randomized 100 patients. Hopefully we'll get to our goal in the next few years.
Now, as you said, the heart team is important in trying to figure out what to do for a specific patient. Based on your knowledge from this paper, how would you talk to a patient? What might you recommend?
Yeah, so I think it's important to take into consideration the anatomy and discuss with the patient both the pros and cons of both the approaches. I have had some patients who would say, even if your risk of stroke is small, they don't want to take that risk. There are other patients who say, the risk of stroke is small, I'd rather get it done now rather than come back for repeat procedures. So in other words, patient preference do matter in terms of what their choices are.
Do you feel a little more confident that you have some more data now after this?
Yeah, absolutely. I think this is one weak spot in terms of randomized trials. For every other cohort, we can say, there is this trial to guide us. But at least now we have some data. It's observational, there are limitations, but at least we have some data to guide us. Interestingly, we also saw in the patients who are already on dialysis, patients who underwent bypass seem to do better. I mean, it's a small group of patients,
Right.
but that group seems to do better. And it's kind of supported by other observational studies in the past. And you sometimes wonder, because all of these patients have heavily calcified arteries, and maybe the PCI techniques we do might be suboptimal in those heavily calcified arteries. So it's something that needs to be investigated further.
Well, all of this information is available to you. It's in the September 15th issue of the Journal of the American College of Cardiology. And for CardioSource World News, I'm Executive Editor Rick McGuire.